Welcome to this video about acute and chronic GI conditions for pediatrics. The first condition we're going to look at is dehydration. Now, the younger the child is, the more at risk they are for dehydration, and then as they get older, that risk starts to decrease. And that's just because babies are such a high concentration of fluid and they have so much body surface area that they evaporate a lot of fluid, and any of those little balances are more likely to cause a significant change in their physiology. When we're talking about dehydration, you can classify it in two main ways. The first is mild, moderate, and severe, and we'll have a look at that in a second. But the second is isotonic, hypertonic, and hypotonic dehydration. Let me use some pictures to help explain this. Let's pretend that the body is this little beaker here. And normal fluid balance is, that much fluid in the beaker, and then there's little dots of solutes through. Okay, we'll call that isotonic. So if someone has isotonic dehydration, we have the same beaker. They have lost equal amounts of fluid and electrolytes. So there's less fluid, but it's still approximately the same concentration of electrolytes. No big change. With hypertonic dehydration, notice the hyper means high, so this is going to be high concentration of solutes. So here's our little beaker, and they probably lost some fluid, but they didn't lose the electrolytes. So there's going to be a higher concentration of electrolytes in here. So hypertonic dehydration means that the fluid left in the body is extra full of electrolytes and solutes and things. So if you do like a sodium level, for example, the sodium level would be high. The hemoglobin and hematocrit would probably be high. So that's hypertonic dehydration. And then hypotonic, we have hypo, low. So, they lost some fluid probably, but they also lost electrolytes. So there's only a few little electrolytes left in the water. When we're looking at pediatric dehydration, this is the most common, the hypotonic dehydration. And that's actually caused by how people treat dehydration. They replace the water that's lost, but they're not very good at replacing the electrolytes. So we often end up with low sodium, low potassium, and probably low fluid levels as well. Depending on what kind of losses you have, that will dictate what you need to replace then to bring the patient back up to healthy and normal. So, for example, with the isotonic dehydration, we'll need to add back water and electrolytes. So, an isotonic solution would work really well to treat that. If we have hypertonic dehydration, they really don't need the electrolytes, they probably just need the water. So a hypotonic solution would fix that. And then for hypotonic, we need to replace the electrolytes as well. So we often don't go to a full hypertonic solution because the kidneys are able to get rid of the extra water, but we might need to add a specific dose of, say, potassium or any of those individual electrolytes that are particularly low. If we want to classify by mild, moderate, and severe, then we can use either the percentage of weight lost or this table of symptoms. And you'll see different tables that might be slightly different. But the point is mild dehydration has mild symptoms. Moderate, you start to see some good symptoms of dehydration. By the time you get to severe, this becomes a medical emergency, and we need immediate medical intervention or that child will not do well. So if you look across the top, we have 3 to 5% lost, 6 to 9%, and then greater than 10%. And this is the weight lost because of fluid lost. In order for us to calculate that, we would need to know the child's healthy weight. So the weight they were right before they got dehydrated. whether it's dehydration from being, stuck in the desert or from having nausea, vomiting, diarrhea, or not eating enough, whatever it is, you'd need to know their weight right before they started losing fluid. And the challenge is we usually don't know that weight. Kids are growing rapidly, so often the most recent weight we have on them is at least a few months old, and that's not going to do us any good because they should have gained weight in the past few months. So instead, we'll look at their symptoms. So, are they basically well appearing, or are they starting to look sick, or do they just look bad? This word lethargic in pediatrics doesn't just mean sleepy like it might mean in your vocab book from high school. Lethargic means truly ill appearing. They're hard to rouse. They're really out of it, kind of floppy. So lethargic should always set off alarm bells in your head, and you want to make sure you don't use it unless you mean that they really look sick. Other things we often look at would be, vital signs, cap refill, whether they're making urine, right? Skin turgor. Now be careful with the skin turgor, because on little bitty infants, their skin turgor will be good pretty much all the time. And remember that with elderly people, their skin turgor might be bad pretty much all the time. So skin turgor is really age dependent. For blood pressure, for pediatrics, notice that it kind of goes normal, and then suddenly drops. For adults, we'd see normal, and then, maybe slightly low, and then lower. But pediatrics, they're really good at what we call compensating, so they can kind of maintain until they're really sick, and then that blood pressure will suddenly drop. So don't rely on just the blood pressure to give you symptoms of someone having, dehydration and the severity of it. If you were going to calculate percentage of weight lost, you start with healthy weight minus sick weight, divide the whole thing by healthy weight, and multiply by 100. So let's do an example up at the top here. Let's say you have a child who normally weighs 35 kilograms, and today they weigh 33 kilograms. So put that over 35, the original. So what we get is 2 over 35, which equals 0.057. Multiply that by 100, and I get a 5.7% weight loss. So actually that's a -2 and a -%. But anyway, so 5.7% weight loss. We're kind of right on that border between mild and moderate dehydration. For the management of dehydration, the first thing we need to do is figure out why the child is dehydrated so that we can remove the underlying cause so that they don't continue to stay dehydrated. So for pediatrics, it's usually some kind of stomach bug, nausea, vomiting, diarrhea. It might be with a really small infant, for example. Maybe they just have had very bad PO intake and we need to work on feeding with them. As we already discussed, burns, if you lose a large percentage of your skin, can lead to dehydration. Or any of the respiratory conditions. If the child has a really rapid respiratory rate, they'll be breathing out extra water, and so they'll be at a higher risk for dehydration too. So we want to try to treat that underlying cause, but in the meantime, we need to then address the dehydration that already exists. So a lot of times you will see a BMP, that's a basic metabolic profile. That's where we're checking all the electrolyte levels, the glucose levels, the kidney function. So that gives us an idea whether we're looking at isotonic, hypertonic, or hypotonic dehydration. We might get a CBC. You can look for infection with the CBC, of course. But what you would also expect to see is an increased hemoglobin and hematocrit. Because, of course, the blood is made up of a lot of water, but then red blood cells. So if you lose the water, now on the labs, it suddenly looks like you have more red blood cells. You don't really, of course. It just looks like it. They're more concentrated. So your hemoglobin and hematocrit will look elevated. A urinalysis can show us how concentrated the urine is. Especially the specific gravity is useful there. And then we can track the specific gravity over time to watch the urine become less and less concentrated. So that's a nice way to track rehydration without having to draw blood. And then weight here is bolded and underlined because weight is really our best indication of fluid balance over time. So we'll weigh the patient when we first start caring for them, and then we'll get a weight at least every day. Sometimes you might even be getting it twice a day if we're really careful about that fluid balance for that child. To treat the dehydration, we need to get fluids back into the patient somehow. So we have two options. We can do oral rehydration or we can do IV fluid rehydration. The other sort of two considerations is how quickly you want to give the fluids. So if we give it in one big push over, half an hour or an hour, we call that a bolus. And that's great for sort of the initial stage of rehydration, but we can't force that much fluid on the body for too long. So one, maybe two boluses is all the body can handle, and then it would start to go into fluid overload. So then we'd slow it down and go to a continuous infusion of fluid. Now, infusion makes it sound like an IV, but we can do the same kind of technique even if we're doing oral medications. Oral fluids. Whatever we're doing, the fluids should contain water and electrolytes, and then usually we put sugar in there as well so that there's some sort of energy source for the child. At home, parents can make their own rehydration solution by taking a liter of water, or for you Americans, that's about a quart, and then a teaspoon of salt and 8 teaspoons of sugar. You can make it even easier by saying a liter of water, a 2-finger pinch of salt, and then a big handful of sugar. And mix that all together, and that gives us approximately the right concentration of fluid for the patient to drink. You can also, of course, buy Pedialyte or Drip Drop, or the World Health Organization makes oral rehydration solution packets that you dissolve in water. Gatorade can be okay if you get the low sugar option. Otherwise, it tends to have too much sugar and can make things like diarrhea worse. So just anything that's, water, sugar, and electrolytes. That could also be, say, Sprite to get your water and sugar, and then some pretzels to get your electrolytes. So however the child can take those things in, that's okay. We just don't want to neglect any one of those 3 components. If we're doing IV fluid, you might see normal saline like for a bolus in the initial stages of rehydration, but that's actually more sodium than children need. It's too much sodium. So we'll back off and we go to usually half normal saline, so that would be 0.45% sodium chloride. If you have a really tiny little baby, you might even see 1/4 normal saline. And then we usually mix in some dextrose, so it'll be D5, half normal saline. And you might even see a little bit of potassium chloride mixed in if their potassium level was low as well. We did the daily fluid requirement calculation when we were talking about tonsillectomy the other week. The only thing I added here is if you're figuring out an IV rate for those continuous fluids, you would, get the 24-hour requirement and then divide by 24 to get the hourly requirement. If somebody's dehydrated, what they usually do is take that requirement and then do kind of like 1.5 times the IV fluid rate. For a bolus, it's again weight-based, and it's just going to be 20 milliliters per kilogram usually. Of course, that's up to the provider to decide exactly what they want to order, but that's about what you would expect. One of the most common causes of dehydration for pediatrics is gastroenteritis, also known as the stomach bug or the stomach flu. You might actually see it abbreviated AGE. That stands for Acute Gastroenteritis. So, just translate the word gastro, the stomach, entero, the intestines, and it's inflamed for some reason. In pediatrics, it's often a virus. Some of the really common ones are rotavirus, but we have a nice oral vaccine to protect against that. Enteroviruses, there are many kinds. They're really common. And then norovirus is a super contagious virus that will spread through like a summer camp or a daycare or even cruise ships. So you might see like an outbreak of norovirus. There are plenty of other viruses that can cause it too. And then occasionally it's bacterial. If it's caused by bacteria, we often call it food poisoning because the most common source for the bacteria to enter the body would be through contaminated food. I'm sure you all have at least some experience with gastroenteritis. So hopefully this is familiar to you. But of course, the most common symptoms are vomiting and or diarrhea. In kids, sometimes that diarrhea even has a little bit of blood in it, especially if it's more of a food poisoning kind of picture. Of course, you'll have stomach pain and or nausea. And then especially kids might get fever with that, whether it's viral or bacterial or, whatever the cause is. If we decide we want to figure out what's wrong with the child, usually all that happens is we kind of look at the child and say, yep, those symptoms match some kind of stomach bug, go home, just make sure they stay hydrated, and that's about as far as we go. But if the symptoms are particularly bad or they've lasted several days, they might get a stool culture to try to identify what the pathogen is. They can be a bacterial culture or they can do a viral culture or even rapid antigen testing for the viruses to try to identify the pathogen. Sometimes that can help guide our treatment. And then to check for dehydration, they'll often do that BMP in there as well. Again, usually we're just supporting the patient, antipyretics if they have a fever, keeping them hydrated, treating any symptoms. But we don't usually want to do antibiotics. If it's a virus, of course, the antibiotics will only kill off the beneficial bacteria in your gut, and that's no good. And then certain kinds of food poisoning, especially with E. coli, if you treat with antibiotics, then you cause this massive die-off of bacteria and can actually cause toxic waste products to build up in the body, and you can cause kidney damage. So the antibiotics in that case do more harm than good. So the term we use here, self-limiting, usually if you just sort of leave it alone, the body manages to fight the infection by itself, and the patient recovers without any more intensive treatment. To support care, of course, we want to make sure the patient is getting nutrients and hydration. If the child is vomiting, it can be a challenge to get fluids into them because anything you put down in their stomach, they might bring right back out. So we want to do little bits, but frequently. So even if the parents sit there with a little medicine measuring cup that, came off their cough syrup or something, just maybe a tablespoon of fluid at a time every 15 minutes, just so that you're constantly putting something in, but the stomach has a chance to absorb it rather than trying to drink a whole 8 ounces all at one time. If the child is thirsty, it can be a real challenge to try to limit them, but that's why the little cup is going to be useful. Of course, if we're in the hospital, we'll just often go right to IV fluids. If you are in another country where it's difficult to get the sterile supplies that you need for IV fluids, you might even see an NG tube, and then you can do just slow, continuous hydration through the NG tube. A lot of parents will be tempted to go out and buy an over-the-counter medication that stops diarrhea if that's their child's issue. And certainly it will stop diarrhea. What it does is it stops all of the peristalsis in the intestines. So there's basically no movement of any stool at all. You kind of shut down bowel movements. But all that does is mask symptoms, and then it actually allows the pathogen to remain in the intestines and continue to attack all the cells within the intestine. So when the medication wears off, the patient is actually sicker than they were when they first took the medication. So we would only use those over-the-counter antidiarrheals for things like chemotherapy-induced diarrhea, where there's actually, no pathogen. Or say somebody has, traveler's diarrhea and they need to get on an airplane for 8 hours to get home. Okay, maybe they need it in that case. But, for a normal stomach bug, we're going to avoid those over-the-counter medications. The other thing that we're going to avoid is the brat diet. Maybe you've heard of this before. For many decades, it was sort of the standard of care for diarrhea. So B stands for bananas, R is rice, A is applesauce, and T stands for toast. And you can see that this is a really bland diet, and it's also low residue. You know, there's like no whole grains or anything in here. This should be white toast, by the way, no butter either. And people noticed that diarrhea slowed down if your patient only ate these 4 foods. And that's true because they're really easy for the body to digest. And so there's just not much to come out the other end. But you'll also notice there's very limited nutrition in here, and especially there's very limited protein. So although the diarrhea slows down, the symptoms stay around for a greater number of days overall. If you just feed the patient their normal diet, get them as much nutrition as possible, the diarrhea might look worse at first, but then the body's able to heal faster. So you'll definitely encounter patients who have heard of the brat diet, but we want to educate that now that we've researched it, now that people have actually tested it to see if it works, we have found that it is not useful, and we want to just get back to normal diet as soon as we can. So overall, it's just all about educating the parents to try to help them care for their child at home. And as long as they're following all your instructions, most parents are perfectly able to stay at home. Only very rarely do we get to a point where the child really does need to come to the hospital for IV hydration. All right, now we're going to transition to appendicitis. This is obviously inflammation of your appendix. So here's a picture of your appendix. Here's your small intestine, and this is right where it connects to the large intestine. And then you've got this little appendix hanging off the end. The word appendix means sort of extra stuff. So when it was first identified, people didn't know what it was for. We have since learned that it has a lot of lymph tissue in it, kind of like your tonsils. So we don't want to take it out if we don't have to, but kind of like your tonsils, it's not necessary for life. So we can take it out and you're fine without it. What happens in appendicitis is something sort of blocks off the opening of the appendix, and then it gets all inflamed and infected. So then it causes pain in the right lower quadrant of the abdomen, and then patients get fever. Some patients will feel really nauseous and start vomiting. Some patients say they're constipated. But there's generally going to be some kind of description of not feeling well along with the stomach pain and the fever. To diagnose it, we're going to rely on the surgeon to make the final decision. So they'll come in, they'll do clinical exam. This is McBurney's point here. You kind of draw a line from the hip bone to the umbilicus, and kind of 1/3 of the way up, that's specifically where if you press, then the patient will complain of pain. That's, approximately where the appendix is. And specifically, we're looking for rebound tenderness. So when you push in, it might be a little sore, but when you let go, it'll be particularly sore. On a CBC, you would see elevated white blood cell count. If we're really not sure what's going on, they can get some imaging. They'll try ultrasound, although usually we don't have great luck with that. They can do CAT scan or MRI. And that's particularly important for adolescent girls because your ovaries are also approximately in the same location. So this abdominal pain here could be an ovarian cyst or an ovarian torsion or something. So we can't assume it's the appendix. For a male patient, they're less likely to get imaging because it's more likely to just be the appendix. If somebody is then diagnosed with appendicitis, sort of the classic treatment is to do surgery to remove the appendix. In recent years, they've also started treating just with antibiotics. So for cases that we caught, more towards the early stages of inflammation, if you just do a couple of days of antibiotics, you can treat the infection, and then there's no surgery needed. So there are pros and cons to that approach. Of course, anytime you do surgery, there's always a risk. And then you have the recovery time from the surgery. But with the antibiotics, there's a chance that you'll end up needing surgery anyway. Even if it's not, this week, maybe in 3 years, your appendix will get infected again. So you might need surgery at that point. So that's sort of it's a regional decision. There's kind of fads as to how people treat appendicitis. So different surgeons might have different preferences. Sometimes they'll actually give the patient the choice and let the family decide what they prefer to do. So, you could see either one there. But we definitely want to treat appendicitis. If we let it go untreated, the appendix usually ruptures. And so we can end up with abscess, the intestines can perforate, you can end up with peritonitis, which leads to sepsis, which can quickly lead to death. So this is not something to be messed around with. We don't delay care of appendicitis. We take care of it as soon as we've identified it. If it's treated appropriately, we see full recovery. There are many, many people in this world who are walking around without their appendix and they're perfectly fine. If it's untreated, we can see serious complications and death. And if we get in sort of that gray area where the appendix did perforate and we did end up with several abscesses in the abdomen, but the patient did then have surgery and we were able to do IV antibiotics and we were able to treat the patient, those patients can end up with a lot of scar tissue in their abdomen. So they might have ongoing issues with their intestines for years just because of the consequences of that massive infection. All right, next we're going to talk about intussusception. Now, this is always a challenge for anyone with pronunciation or spelling difficulties. So it's intussusception. And if it helps you remember, you can think of it as one side of the intestine going into susception, into the other. So the most common site is right here where the small intestine and the large intestine meet, simply because the small intestine fits so nicely inside the large intestine. So in it slides, and why that goes in, we don't know. That's a good question. We just know sometimes it happens. And then let's look at another picture. Then what happens is the larger piece of intestine continues its normal peristalsis. So it kind of squeezes in all around the smaller piece of intestine and starts to cut off blood supply, causes a lot of swelling, and so it causes these distinctive symptoms that we see. So first of all, we see pain. It's very, very painful. This is by far more common in children. So usually how the parents describe it is the child was happy and playing and doing just fine, and then suddenly started screaming in pain and guarding their belly and not letting anyone touch it. And then the piece of intestine can kind of slide right back out again. Right back out where it belongs, and the pain's gone. Ta-da! All better. So the parents are left wondering what the heck happened. 1 second, my child looked like they were in the worst pain in their life, and then the next second, they looked perfectly fine. And that can happen again and again. You get this intermittent pain cycle. The more the intestine slides in, the more swollen it's going to get. So eventually it will just kind of get stuck. So those episodes of pain will get longer and longer and longer until it's more like constant pain. All of that sliding in and out and irritation of the intestine causes bleeding. And that bleeding mixes with mucus that's produced by the irritated intestine. So we get what they call currant jelly stools. Now, we don't eat a lot of currant jelly in the United States. It's more of a British thing. But you could think of like raspberry jelly, where it's like dark, like reddish, purplish color, but still clear. You could see through it, but it definitely has a color to it. So that's the currant jelly stools. And then sometimes you can actually feel this mass in the lower abdomen as well. The longer this happens, the more likely you are to have permanent damage or even death of the intestine. So we might have to actually remove a piece of the intestine if we don't treat soon enough. Here are some of the risk factors that we know increase your chances of getting intussusception. Any kind of inflammation seems to make it happen more often, whether it's a viral illness or like an inflammatory bowel disease. If a patient has some kind of chronic GI problem that requires them to take motility medications, that can do it. Or Meckel's diverticulum is where you end up with this extra little pocket coming off the intestine, approximately where the umbilicus was as a little bitty baby. And that can kind of get captured by peristalsis and pulled up inside. So, these are all things that might cause you to have a higher risk of intussusception, but sometimes we have no idea why it happened, and it just seems to have come out of the blue. Here's another listing of your symptoms if you prefer words instead of pictures. And then the treatment and diagnosis happen kind of at the same time. So we'll always do an enema, and then it's either with air, so just kind of bubbles, or they'll use barium, which is that thick whitish liquid that shows up on an x-ray. Air also shows up on x-ray, and that's why these two are used. What they do is they take progressive x-rays as they're injecting either enema. And what you can see here is here comes the barium up the intestine, looking good, nice and solid. And then it hits this section of the intestine here, and it starts to look like a spring or a slinky. And that's because there's this piece of intestine that has telescoped inside on itself. And so the barium can only get in these tiny little spaces between the two layers of intestine. To then treat this intussusception, the surgical team would just push a little more barium to try to force that piece of intestine back out where it belongs. Or again, air could be used. Now the danger is that if you force too much, this intestine that's already very irritated could actually rupture. So there's always a surgeon like standing by, ready to go just in case, but it only occasionally requires surgery. The other time surgery is required is if it happens again despite having all the air or barium in there. Then the surgeon will go in, they might actually remove a piece of intestine, or they might put little tiny sutures kind of on the two ends of the intestine to hold it in place so it can't telescope again. So the surgeon's always around ready to go, but we don't always need surgery as a treatment. Sometimes people will try an ultrasound or just a simple x-ray, and you get like a bullseye kind of pattern in the intestine. But the gold standard, the official diagnosis will always be an enema. Okay, next condition here is called pyloric stenosis. The pylorus is this valve here at the bottom of the stomach. And stenosis means a narrowing or a closure. So what happens is the muscles here get too strong. They grow too much. That's the hypertrophy. And it just closes that valve kind of permanently. So anything that comes in the stomach gets stuck. It has nowhere to go, so it'll go right back out. This is more common in males, and it's also more common in people who have like Caucasian kind of genetic makeup. It's interesting that although it's definitely a baby diagnosis, this is always a baby who's just a few weeks old, it's not present at birth. It has sort of this slow, gradual onset. So baby will be eating, they'll be gaining weight, they'll be doing well, and then they start to spit up a little bit after each feed, and then the muscle gets bigger and stronger and bigger and stronger, and it turns into projectile vomiting, sometimes in the middle of feeds, or sometimes it's right after they finish feeding. I put a video on Canvas for you. Here's the link. So you're going to watch that just to see what the projectile vomiting looks like. It's important to notice in the video that very little of the vomit actually gets on the baby. I can't tell you how many times I've heard parents say, man, my baby just projectile vomited all over the place, and I had to change his sheets, and I had to change his clothes, and I had to change. Well, if it gets on the baby's clothes, then it's not projectile. By definition, that projectile vomiting means it travels several feet because of the force of that expulsion behind the vomiting. So baby shouldn't get too messy. Parents, chairs, walls can certainly get messy. So as that vomiting becomes more and more severe, more and more frequent, of course, the baby's not absorbing any nutrients or any fluid. So we're going to see dehydration. We're going to see poor weight gain. There's nothing to digest, so they won't have any bowel movements. So those would all be good clues that this is more than just baby spit up. This is really something that needs to be addressed. So in they come. Again, it's going to be the surgeon who makes the official diagnosis. They can sometimes actually just palpate to feel the pylorus. Officially, they like to do an ultrasound and measure that muscle, and then they have guidelines about how big it's allowed to be. They might do an upper GI series. This is where they do lots of x-rays in a row and then feed the baby barium and watch to see where the barium goes. And if it gets to the pylorus muscle, stops, and then the baby vomits all over the x-ray table, then that's another good clue that it's pyloric stenosis. If you see the barium go through the pylorus muscle and into the intestines and off it goes, then you know that this isn't pyloric stenosis. To treat it, we just do a surgical correction of that pylorus. There's kind of 2 layers of muscle that are on top of each other, and they'll loosen the outer layer to allow food to then travel through there. But before you can send a baby in for surgery, you need to make sure they're stabilized. So they often get some IV fluids. We get all their electrolytes balanced out again. They've just been vomiting for several days, if not weeks. So they will have lost a lot of acid. So they might be in metabolic alkalosis. So we might need to correct that. So we get them all stabilized, and then they go off for surgical correction. When they come back, it's just a tiny little incision. Nursing care would be all about pain management and then trying to get them eating again. And we usually start just with Pedialyte, something really simple to make sure that they're tolerating that before we go back to their regular diet of breast milk or formula, whatever they're usually eating. And then they usually grow up and they're just fine, and this is a surgery that people even forget they had. Their mom remembers they had surgery when they were 4 weeks old, but of course the patient themselves has no memory of it, so they might not realize they've had abdominal surgery in the past. Okay, next condition is called tracheoesophageal fistula. That's what TEF stands for, tracheoesophageal fistula, and or esophageal atresia. And that's what we see in the pictures here. So here's normal anatomy, right? Here's your stomach. Here's your esophagus going up into your mouth. And then here's your trachea, and then branches off into the lungs. So this is normal. We like it. A tracheoesophageal fistula is this one here. This is all by itself. And a fistula is an opening where there shouldn't be an opening, a hole between 2 body cavities. So an isolated fistula, there's just a hole between the trachea and the esophagus. So anything the baby swallows down the esophagus can sneak into the trachea. Or anytime the baby breathes, you can get air going down into the stomach, so they can just sort of mix back and forth. Obviously not ideal. They might do a lot of coughing when they eat. They might be really gassy, have a lot of burping problems, that kind of thing. An isolated esophageal atresia is where the esophagus just sort of stops. It never fully connected during development. So there's no hole here, but again, the baby won't be able to eat. There's just nowhere for food to go. So it just kind of stops, and then the baby would just have to kind of cough it back out. There's nowhere else for that food to go. The real problem is when these things are connected in one way or another. So this one is particularly problematic. The esophagus stops, but there's a fistula, so any food you put down this baby's throat is going to go directly into their lungs and just flood their lungs. There are other variations, any reflux coming up here is going to go directly into the lungs. Here we have kind of a mixed match. It's all going everywhere. So obviously this is a problem when this happens. It's pretty obvious that this is happening at birth most of the time. There's going to be a lot of coughing and choking and vomiting anytime you try to feed the baby. Because of the problems with the food going into their lungs, they can quickly become cyanotic. So when we start to suspect that, we can try to pass an NG tube, and then if that doesn't go down, that would be a sign of an esophageal atresia. But ultimately, they need to do imaging to actually see what's going on, figure out where the holes are, if the esophagus is connected. So it can be ultrasound, it can be CAT scan, it might even be an endoscopy where they send the little camera down. So we just need to have a look to see what's going on. Obviously, if you suspect a TEF or an EA, you're absolutely not going to feed that baby. We'd keep them completely NPO, keep the head of the bed elevated, and have them on IV fluids until the whole surgical team can come and make an official diagnosis and make a plan for correction. It is all surgical repair, so, depending on what the problem is, we'll see different types of surgeries. A lot of times it has to be done sort of in stages. Maybe you patch the hole one day and extend an esophagus the other day. So most of these babies will start with a PEG tube, a G tube, so that we feed them directly to their stomach instead of trying to deal with all of the mismatch of anatomy happening in the throat. Because of that G tube, we can see that babies don't learn to eat very well, so they might have a feeding intolerance as they start to get older. Any kind of surgery on the esophagus can cause strictures where like scar tissue hardens and the esophagus can't expand correctly, so food might get stuck as they try to swallow. Or maybe the esophagus is a little too relaxed and it's allowing acid to come back up out of the stomach, so you might get GERD instead. So we can fix the anatomy with surgery, but there can definitely be ongoing problems, at least through the first couple years of life. Sometimes it's just going to follow that patient through their entire life. If we move a little higher up in the GI tract and go to the mouth and the lips, here's another possible anatomical defect we can see at birth. So cleft lip, cleft palate, they can happen together, they can happen separately, but it is a defect that happens early on in gestation. So usually this can be identified even via prenatal ultrasound, so we'll kind of know the baby has it before they're born. If it's more of a mild case, or if it's an isolated cleft palate that's all cartilage, that can be a little harder to see. So we always do a good newborn assessment to make sure we're not missing anything. Here's some pictures of what it might look like. So here's a unilateral cleft lip. Here's a bilateral cleft lip. Here's a cleft palate. That's mostly a soft cleft. There is a little bit of hard palate here. Obviously, this is an older patient because they have teeth, so clearly they survived without a repair. But you can actually see the nasal passageways there. So any kind of food that they're trying to swallow, I'm sure it was a challenge to keep it from coming right out their nose. In a baby with no teeth, it'd look more like this. Sometimes the cleft will actually come all the way through the gum line, and then you'll see a cleft lip that goes with it. So it can be a full facial cleft, or it can be just a cleft palate, or it can be just a cleft lip. Nobody really misses cleft lips on a newborn assessment, and that's pretty obvious. You have to look a little more intentionally. You have to kind of go looking for the cleft palate, so don't miss that. With either one, feeding becomes a challenge. If you have a cleft lip, it's hard for a baby to get a good seal around the nipple to be able to suck. So we use these special nipples that has kind of this hood, and you'll press this piece of the nipple right up against baby's lip to create that seal for them. And then if it's a cleft palate, they can't really suck without stuff coming out their nose. So we use these special Swan's-Ganz valves that it's kind of like you can squeeze it and almost squirts down the baby's throat. So, and then the nipple is particularly long. So it helps us get the milk all the way back towards the back of baby's throat so they can swallow. But notice there's just a little tiny bit of milk in there, so you kind of bring a little bit into this kind of reservoir and then feed, because the last thing we would want to do is dump all this milk right down baby's throat and make them choke. That's not going to help anyone. If it's a minor cleft, maybe just a little bit of a cleft in the soft palate, or just a unilateral cleft lip, sometimes the baby manages to just breastfeed normally, but a lot of times we're not able to achieve a good enough latch on the breast, or maybe all the breast milk comes right out baby's nose. So we'll always work with the speech therapist and then the lactation specialist to come up with the best way to feed baby. A lot of times it does end up that mom needs to pump, and then we feed that expressed breast milk via specialized bottle, whichever one they need. And that can be hard for mom because a lot of moms really want to breastfeed. And then if it's a cleft lip, parents can feel a little bit of embarrassment, or like they feel like other people are staring at them because of the disfigurement on baby's face. So they always need just kind of some extra emotional support. We certainly can do surgical repair of either one. The lip, they like to repair a little earlier. So as early as 10 weeks of life, as long as baby's stable. And if you can repair super early in infancy, then usually there's very little scarring, if any. The palate, they have to wait a little longer to repair because you have to wait for a little more bone development. If it's a really bad cleft, they might have to take a bone graft, and they'll usually do that from the hip. So again, you need to wait for those bones to develop before you can do that bony surgery. So that's going to be more like 18 months if that needs to be done. They do put them fully under general anesthesia, so they usually stay overnight just to make sure there's no complications with that. And you can see that we've got some really pretty good outcomes with those surgeries. ATI NCLEX like to ask about post-op for these surgeries. So we're just going to make sure we're not doing any kind of suctioning in the mouth. We're not letting them have any kind of utensils that they could pull at the stitches. We're not going to do straws. So just trying to keep the mouth as soft and protected as possible. And then, of course, managing pain. That's going to be important. Okay, last but not least is Hirschsprung's disease. Dr. Hirschsprung described it, so that's where the name comes from. You may also hear it referred to as congenital aganglionic megacolon. People don't like to say that too much, and so we go with Hirschsprung's. But if you can remember this congenital aganglionic megacolon, it can help you remember what the heck is going on. So it's congenital. Babies are going to be born with it. It's aganglionic. No ganglia, no nerve cells. No nerve cells, and it causes a megacolon. So the part of the colon becomes really big, and we'll see that's because part of the colon is missing the nerve cells. The nerve cells just never finish migrating all the way down the intestine during fetal development. So it does tend to run in families. It's particularly common in Amish or Mennonite communities because of the smaller gene pool there. It's one mutation that they have a higher concentration of. And it can certainly be associated with other birth defects as well. What happens is in the affected portion of the colon, there's no peristalsis. It's a very small, underdeveloped piece of intestine. So any stool coming through kind of gets blocked up, backed up. So you get a big inflamed portion of the colon, and it's very hard for any kind of stool to pass through the rest of the rectum, the rest of the colon. Now in this picture, it's just a couple of inches at the very end of the rectum that's affected, but it can be varying levels of severity. So sometimes it really is just the end of the colon there. Sometimes it'll be the entire large colon, and sometimes it can actually involve a little bit of the small intestine as well. So the bigger the affected area, the more likely the patient is to have lifelong complications because of that. Obviously, symptoms would be not passing stool or having a real challenge passing stool. They might start vomiting, and we'd be especially concerned if there's bile in that vomit. Bile comes from the small intestine, so if we start to see that coming back up through the vomit, we know that digestion is so backed up that stuff is actually starting to move backwards, which is definitely a bad sign. We see really big rounded abdomens. The babies are usually really fussy. They're not gaining weight well. So really it's just this constellation of symptoms that tell us that digestion is not moving forward the way it's supposed to. to diagnose it, it's probably going to be a surgeon, again, who's doing this. They'll do a clinical exam. They might do x-rays. They might do MRIs. Officially, to make the diagnosis, they need a biopsy of the colon wall, and they can prove that there are no nerve cells in there, and that would sort of prove the Hirschsprung's diagnosis. A lot of times they'll do this biopsy while they're doing the surgical repair, so it's kind of like a last step, because the clinical picture and the x-rays they've taken have been so obviously Hirschsprung's that they don't feel the need to do that beforehand. There is no medical treatment of Hirschsprung's disease. Eating a high fiber diet and taking laxatives isn't going to work because there is no peristalsis in that piece of the intestine. So they will always remove the affected portion of the intestine. And then depending on how much is removed, they might have a temporary colostomy. So you can see the colostomy here for this little guy. After things have had a chance to sort of heal up, they'll do what's called a pull-through procedure, where they take that healthy intestine and then connect it back to the rectum, so sort of reestablishing connections, and the GI tract is back to at least an approximation of what it should look like. Most patients kind of gradually learn then to have normal bowel function, but because the rectum has now been replaced, some patients do have ongoing incontinence issues with stool. There's no issues with urinary incontinence. This would just be stool incontinence. And then if the patient had to have a significant portion of their large intestine, sometimes even, small intestine removed, then of course digestion will be completely impaired. This is called short gut syndrome. So Hirschsprung's is a really common reason why a huge section of the intestine might be removed. It can be some kind of massive infection, especially in premature babies who get necrotizing enterocolitis. They might need a huge section of intestine removed. Older patients with Crohn's disease, again, might lose a big portion of their intestines. So basically, these patients have just lost so much of the intestine that their body's not able to digest the food or absorb the nutrition. Sometimes it's just absorbing the liquid out of the nutrition. The body just is not able to do that. So in order to get that nutrition and hydration into the patient, they will require TPN, total parenteral nutrition. But that has to go through a central line, which is really prone to infection, which then causes sepsis, so that's really dangerous. And TPN by itself is really hard on the liver for these patients. So it's not a long-term solution. Things they've been working on in recent years is a transplant. They'll actually do multi-organ transplant. So they'll transplant the intestines. It might have new liver, new pancreas, depending on what has been affected. They transplant just sort of most of those abdominal organs. Of course, any transplant then comes with a risk of rejection, and then you might have infection. So that's not without risk. So a new procedure that we've started to see recently is called the STEP procedure. So they take a short piece of intestine. This looks like, maybe 3 inches of intestine. And they put rows of staples through it and then cut little incisions in here. So they folded out, a zigzag, an accordion. So we went from 3 inches of intestine to, 15 inches of intestine. And then that intestine will gradually dilate, will gradually grow bigger to accommodate an increased volume of food coming through it. So we, quintupled the amount of digestion that can happen through that intestine. So that's an exciting new procedure we're starting to see more of. That's really helpful for these babies with any kind of short gut. It also can work for adults with short gut, and then it helps reduce those long-term consequences of something like Hirschsprung's disease. Okay, that does it for our discussion of GI issues here in pediatrics. As always, if you have any questions, send me an email, catch me after class, let me know. I'm happy to walk through these things with you.